Hi everyone, this is your lecture for week one. Week one's a little bit easier than the rest of the time, but it's still just as important. It's kind of laid the groundwork for what you'll be doing as prescribers and some things you need to think about. The big thing is you need to know as nurse practitioners who regulates our prescriptive authority, and that's the State Board of Nursing in all states. And whereas PAs are a bit different, the medical examiner usually monitors them. There's been a lot of bad press and maybe even a little bit of bad blood between PAs and NPs in the past. Really and truly, they need to be considered as colleagues. There's some great PAs out there, just like there's some great NPs, and there's some bad PAs, just like there's some bad NPs. So they are trained differently. Of course, it's more of a medical model, and ours is more of a nursing model. And you'll find once you're in clinical practice, you're never going to lose being a nurse, but you are stepping into a medical model, and you do have to start thinking differently. You're going to be treating the patient as a whole person always, of course, but you're still, there's nobody making the decisions for you. The MD that I worked for actually was a nurse first, and she has the perfect analogy. She says a brand new NP usually has a little bit of a hard time, what she calls pulling the trigger. They can make the diagnosis clinically, but they're really a little bit timid on the treatment plan the treatment plan or the intervention, just because they've always pretty much had somebody else tell them what to do, I think, which is true. As nurses, we are forced to work, to wait for someone to tell us what to do. So this would be a totally different role. It's even hard in clinical, if you ask me. I remember my first day in clinical with my NNP being like, oh my goodness, I know what to do at the bedside, even what the docs would tell me to do. But when it was actually me making the decision, I just wanted to be sick. And truly the first day of being an NP, that was the case. A lot of first days, that case. And even now sometimes, I was an NNP for 4 years and now an FNP. There's days now and there's this sinking, there's this knot in the pit of your stomach where, oh my goodness, am I making the right decision? And you do have your MD as a backup, but sometimes they're not available, and sometimes you have to make that decision right then and there. So let me tell you a little bit about my clinical practice real quick. I work for a doctor in internal medicine, and it's a combination of office and rehab/nursing home, which, to be perfectly honest, we're seeing that role more and more for NPs, and it's actually kind of a nice role. The doc I work for also would like me to be credentialed at hospitals, and I told her not at this time. I really felt like it would be too much. She covers 9 rehab/nursing homes, and then she has a huge practice, and it's just her and I, and that was one reason why I said no. Whenever you take a position, make sure you don't let the slide happen. And what I mean by the slide is you'll be contracted to do certain things, and then all of a sudden more and more gets added on, and as a newer NP, it's just way too overwhelming. There's going to be a lot you're going to have a lot of issues with organization of your time even. I mean, I still have this issue. You're going to have a patient that walks in and you have 15 minutes to see the patient, and all of a sudden the patient is playing the Macarena. They came in for supposedly a sore throat, now it's a headache, now I have this chest pain, oh by the way my knee hurts. So things like that. It's really kind of hard to get out of the room sometimes, and I don't know that you should get out of the room. That's the other piece. So, and that's the nurse in us also. We don't tend to blow patients off as much as, I hate to say it, is our MD counterparts. But I love the doctor that I work for. I have a really autonomous role, and as far as being in the skilled nursing homes or the rehab centers, the role might sound boring, but I would encourage you, if you could get some clinical hours in one to see, because if you watch Indeed.com, there's lots of jobs now where it says, where it's a job like mine, where it's a combination of office hours and skilled nursing facilities. people come from the hospital really sick. I mean, I had a post-heart transplant patient even, so it's not like you're just getting nothing. I mean, I've managed CHF, severe COPD, pulmonary edema, sepsis, IV antibiotics, dehydration, all kinds of things that I was really not prepared for. So I just want you to kind of think about what your plans are. So with all that being said, you're in your practice, and then clinical judgment is going to be what, in prescribing, is going to be a huge issue. So for clinical judgment in prescribing, your very first thing that you need to do is you need to make the diagnosis. So I'll give you a perfect example. The other day I was in the skilled facility, and I had a woman who had an acute change. This patient's been on IV antibiotics for bacteremia for weeks, and then she got sent there for weakness, of course, to rehab, and 3 more weeks of IV antibiotics. I see this patient 3 times a week. She's been doing pretty well, and then all of a sudden there was acute change. The nurse called me and said that she was wheezing. Although she was standing 95, she was weak, she just didn't seem right. This woman's been edematous from day one, really edematous. She's a larger patient, but just full of fluid in her legs and even her lower abdomen. So I had gotten a cardiology consult early on, and I had already had her on 40 a day of Lasix. He had put her on 80 a day of Lasix, and then there was this acute change. So with the acute change, I wasn't really sure. I listened to her. She sounded just terrible. Her lungs were awful. I mean, she had inspiratory and expiratory wheezing. She had bilateral upper lobe bronchi. I could not figure out, so what do I have here? Do I have congestive heart failure exacerbation, or do I have a pneumonia now? Because this is a patient who's really deconditioned. You know, even in the skilled facilities, they're only getting 1 to 2 hours of therapy a day. It's not like they're getting a ton. So what do, right? So you order a stat x-ray. Well, this is a skilled facility, not a hospital, so it's like a 4 to 5 hour turnaround time for a stat x-ray. I did have them give her a breathing treatment, and the fortunate thing for this patient is she has a PICC line in, so I gave 20 of Lasix IV, which isn't much, but like I said, what am I dealing with? So this is where your clinical judgment comes in. I had also given her 20 milligrams of prednisone oral, and I had given her a tablet of Levaquin, 750 milligrams of Levaquin. So this is what I'm telling, and I also have now started KCL on her because she wasn't on any, which her potassium is on the higher side anyway. But that's what I'm saying. So this is the clinical judgment piece that comes in. I mean, what are you dealing with really? I mean, I can't see inside of her. She sounds not great. She has no real history, no real cardiac history, although she does have this edema, you know, so what caused it? I mean, there's always a concern for acute MI as well, which she did not have any chest pain. She was fine, not diaphoretic, vitals were perfect. Like I said, statting 95 in room air, not appearing short of breath, just sounded terrible. So that's what I mean. So I get the x-ray back, and yes, it was no pleural effusion, no pneumothorax, no pneumonia, no consolidation, so mild venous congestion, though, and heart enlarged. So once again, cardiology will be seeing her on Monday. She improved with the 20 of Lasix, so right there was your answer. I was in the facility for 4 hours working. I have quite a few patients here, and I discontinued then the rest of the Levaquin because I put it on for 7 days, and I discontinued. I left the Duomneb's PRN, so I left her at her 80 oral of Lasix a day, but cardiology will come and see her in the morning. Because now I think we have a new problem, and you know sometimes bacteremia is that way. The other problem with this patient is, for whatever reason, this is a recurrent bacteremia that she gets, so she's a little bit scary anyway. That's what I'm saying. Even in the skilled facilities, you're going to be challenged, so don't poo-poo a job like that. If someone offers it to you, it might be a nice starting point. Actually, the facilities are less stressful than seeing a patient every 15 minutes. I get a little stressed when I feel like I'm behind. So then the other piece about once you've got your diagnosis, the other piece you need to worry about is what drug am I going to get? So this week's case study, and I mean the one that's the assignment writing the prescription, you were given somebody with a pain issue. And you were also given that he had gotten some pain medication from other providers. At any rate, the biggest thing with this is you have to worry about cost effective. I ordered an eye drop or an ear drop for somebody one time who had no insurance, and they called me up screaming because the ear drop was going to be $156. So you need to print off those Walmart $4 lists, the CVS list, and all Osco, whatever you have, and you need to know what the options are. There are a lot of people that have no drug insurance, and even if they do, it may not cover very much. So you always want to choose the cheapest drug with the best effect. That may not be, you may have to choose the free Lipitor at Meijer opposed to the Crestor that you really wanted to get. So that's huge consideration is the cost. I mean, and that really is the number one thing that we need to be paying attention to is the cost effective. You never want to choose a new drug. They're not tested long enough. They're super pricey. There's no generic. So you want to try the most cost effective drug that'll work the best. So also when you're writing a prescription too, a lot of you had mentioned putting an NPI number on. That's a good idea. Get in the habit of knowing, well, you'll get a DEA number after you're all licensed, but get in the habit of memorizing that DEA number because no matter where you work, you're going to be writing a lot of C2s, C3s. For sure a lot of C3s, but if your physician credentials you for C2s, you can. In Illinois, we cannot write for C2 unless our collaborative physician says that we can. So that's something that you might want to work out. So that's your higher gun drugs anyway. It's your Percocets, your morphine, oh my gosh, I can't speak, and then fentanyl patches, things like that. But even 2Ns are like your Adderall. So be cognizant and memorize those schedules. They'll ask you about the schedules in our testing, but of course they're not on the boards. But just really be careful. The other thing I wanted to talk to you really quick about was the minute you have a license, the minute friends and family will come out of the woodwork and want you to write prescriptions for them. It's a little bit unethical just for the fact that these patients, you write for something for them, they are now your patients. Just be aware of that. You are liable for them. So you never know when that's going to ever come back on you either. Of course, an emergency situation, I wouldn't even hesitate, but for the most part, I mean, I've had somebody ask if to write for, their husband or whatever, and I'm just not going to do that. Just tell them no. Just tell them no, it's not ethical, that's all. You need to learn how to say no. That's the biggest thing. And I would never, ever, ever write a controlled for anybody that was not my patient in the office. It's just not okay to do that. So they feel that nurse practitioners are going to thrive under this new affordable health plan, but I told the class prior to you that I'm not so sure that that's really true. For whatever reason, once affordable health care the minute it passed, all the jobs went away, so it was a little frightening. They are coming back though, so people are trying to feel things out. It's a little bit disheartening. There may be jobs out there, but the pay is not really probably what you think it is, possibly. I posted something on my real Facebook about what the AANP had done, a study about what nurse practitioner pay was. And honestly, there are a lot of staff nurses that can possibly make as much as a nurse practitioner. So the problem is, like I know my physician, she struggles to keep the lights on, and if I don't see one patient every 15 minutes, it actually is a problem financially for her. So if I'm not booked sometimes, she'll cut my hours, and you have to kind of be respectful and understand those things too. So one just last thing, when you're in clinical this week, I really want you to be paying attention to which medications the doctor that you're with wants you to prescribe and why. You're going to fall into the same thing as I fall into and everyone else. You're going to have about 10 drugs that you always give. You're going to have your own little cookbook style of treating patients. But with that being said, I'm encouraging you to always keep reading. We are totally guided by those national guidelines, the JNC 7 and 8. Well, 8's coming up soon, and even as far as antibiotics, there is a guideline for everything, and that's what keeps us out of court. When we step outside of the box and don't follow those things, that's when we're in trouble. I'll give you a perfect example. Ambien. Ambien A should probably never be given to anybody, but women are only supposed to take 5 milligrams of Ambien. There was a huge study that came out, and it was a no-no to give the 10 milligram tabs to a woman. The physician I work for and 3 other physicians that I know had no idea because they just are so busy they don't pay attention to those things. So that's the trap that we can't fall into. There is no protection for you when you step outside of those guidelines. And they change often, they do. All kinds of things change, just like now. Women, if they've never had a bad pap smear, don't have to have one for 2 to 3, really 3 to 5 years. So that's what I'm saying. Just pay close attention to those guidelines. Those guidelines is what keeps us out of trouble. And it also keeps us being lifelong learners, which is the most important thing.